Good morning and welcome to our Monday Night IBD video brunch series. This series is supported by educational grants from AbbVie, Janssen, and Takeda. I'm Dr. Aline Charabaty, founder of Monday Night IBD and the clinical director of the IBD Center at Johns Hopkins School of Medicine at Sibley Memorial Hospital in Washington, D.C. I'm joined today by my colleagues and friends, Dr. Tauseef Ali. He's the medical director of SSM Health Crohn's and Colitis Center. Dr. Drea Maier, PharmD. She's the system director of the ambulatory pharmacy at SSM Health. And Dr. Sarah Koubysi, PharmD and clinical pharmacist at SSM Health Crohn's and Colitis Center. Our faculty disclosures are shown on the screen. Let's jump into today's discussion. We are going to talk about the ins and outs of an IBD pharmacy and the role of the IBD pharmacist in the care of patients living with inflammatory bowel disease. Drea, I'm going to start with you. Historically, we have seen pharmacists' role in the hospitals and in retail pharmacies. How is the field of pharmacy services evolving, and can you share some updates with us?
Yeah, thank you for the question and the opportunity to talk about our clinical pharmacy roles. It definitely has evolved over the years. For those who aren't familiar, pharmacists go through pretty extensive education at this point, typically 4 years of graduate school in a doctorate PharmD program. And then many choose to complete additional training in residencies or fellowship beyond that, sometimes more general residencies and sometimes specialized beyond that even so. So with kind of that education and training focused on, medication therapies and medication optimization, pharmacology, all the things, and really the therapy guidelines available. We feel that with the training, the pharmacist really can play a critical role in direct patient care and really become that therapy or medication expert as part of the team member and the care team. And so that, I think those are some key elements as to how the profession is evolving and has evolved. I think certainly there's roles in the community retail setting as well as the hospital setting to use that expertise and be part of the care teams. But in the ambulatory kind of clinic-based setting is probably where we're seeing the most growth in those opportunities. And I think our provider partners and nursing partnerships have really allowed us to step in and use our expertise to impact patient care directly. And really the role of kind of ambulatory pharmacy is exactly what we're going to talk about today, and what Sarah is doing in the IBD clinic is really using kind of the top of our license skills and evidence-based medicine to help select the appropriate medications, monitor them safely, and ensure that the patient has kind of a comprehensive review of all their medications and education that goes along with it. So there are many pharmacists within SSM, but certainly many health systems that serve in these ambulatory pharmacy roles now. So we have, for example, this is a new venture for us in the GI and IBD world, but we have some established programs for our primary care clinical pharmacists who do a lot of chronic disease management with diabetes, hypertension patients, asthma, COPD patients, et cetera, and really work under collaborative practice agreements with those providers to optimize medication therapies and make sure patients are on the most safe and effective therapies.
Thank you, Drea. That was very useful, and I'm excited that pharmacist role is expanding. Like you said, so much education and so much expertise goes into becoming a pharmacist. So we are glad to have you on our side as clinicians. So on that, I'm going to turn to Tauseef. Tauseef, as a gastroenterologist with a focus in inflammatory bowel disease, why is the clinical pharmacist important and a key player in the practice of inflammatory bowel disease and the care of patients with IBD?
Yeah, I think over the last several years, we have recognized the importance of having clinical pharmacists joining our hands, especially when it comes to chronic disease management, And for our discussion today, inflammatory bowel disease, as we all acknowledge, it's a complex disease with limited therapy options, although we have seen a growth in our medical therapies in terms of availability of biologics, biosimilars, small molecules, and then there are so many phase 2, phase 3 trials that are happening. So in future, we'll even have more complex management algorithms for our patients. So I think this is a very timely intervention where we are, many practices and many programs are seeking out and developing this collaboration with clinical pharmacists. I see it kind of like multi-faceted collaboration as a physician, as a gastroenterologist, and then as an IBD expert. We all have seen kind of like almost a burnout when it comes to prior authorizations, benefit verifications, step therapies, denials, appeals, peer-to-peer. And we hear this value-based healthcare model. We talk about patient-reported outcomes. We can't do it by ourselves. With the load of patient care, with visits, with us busy doing all other clinical practices, I think it's very critical to have a pharmacist to help us out with all these things that I mentioned. So that's one area where I think pharmacists can and are now playing an important role to help us streamline everything. The other day, Sarah might tell you that we had this peer-to-peer, and she successfully and very beautifully handled that. So it actually saved my 30 minutes and I could see another patient. Same thing with prior authorization. The other thing is this collaborative agreement where they actually can independently see a patient also. So it actually helped me have even more meaningful discussion where a pharmacist can sit down independently and have this visit, go over mechanism of action, side effects, how to monitor, develop a strategy that is very personalized to that patient, come up with the backup plans, give them expected timelines of drug approval, bridging that time with some medication. So I think the role of a pharmacist at this point, I don't think so it can be dismissed. And if someone really want to build a strong program, such as an inflammatory bowel disease program, clinical pharmacist is the critical piece of that program. So I think we will see that in future, we'll have more and more understanding how this relationship can even be strengthened and how we can use our clinical pharmacists, not only in ambulatory care, but inpatient and in transition of care. So the role is just going to be phenomenal in future also. And we all will be learning with each other.
Yeah, thank you, Tauseef. Absolutely. I couldn't agree more. And I wanted to hear from Sarah's perspective now. How do you think a pharmacist can contribute and bring value to the IBD practice?
I think that there are several different ways that we can contribute and help bring value to different IBD practices. I think that one is going to be with like medication selection. I think that oftentimes providers will give patients several different options to consider moving forward with their treatment, and we can really sit down with the patient and go over the different options in detail to help them make the selection that's best for them. I think we can also help with patient education. Again, really sitting down and being able to go over these medications in depth and teach them how to use them correctly. Like, for instance, we have an on-body injector that some patients struggle with, and just taking the time to go over with them how to use it so they don't struggle when they get home. I think another way we can help is with, like Dr. Ali alluded to, the peer-to-peer discussions, where we can help step in and help with the prior authorization process, and with those discussions to free up the provider's time to do other provider-specific tasks. Drug monitoring is also an area where we can be helpful to just helping identify good times to do that, and then assessing when those labs come back if maybe regimen changes need to be made. And I think lastly, we can also help promote health maintenance, sitting down with patients and talking about the importance of vaccines, finding out if they're up to date or not, and talking about maybe annual skin checks or annual pap smears as indicated.
Thank you, Sarah. That's wonderful. And, I would love to hear from you and both of you, Tauseef and Sarah. How does this work in practice? You see a patient, Tauseef, you decide to start on therapy. Do you call Sarah? Do you have dedicated pharmacy appointment? How does it work in practice, in practical manner? If you can tell us how you're doing this in your practice and how we can maybe translate that in our own practice of IBD.
So in our practice, number one, we have this collaborative agreement so Sarah can actually see those patients independently. So if I see a patient or one of my advanced practice providers see a patient and in the clinic, let's say if it's a new patient or if a patient we're starting a new medication or changing a medication, we tell them that, well, we're going to have a visit arranged for you with a pharmacist and she will go over this with you in detail. Unfortunately, due to some laws and policies, we can't have the same day visit in our practice, so we have to separate that visit out. But it works really good because we have telehealth facilities now, but we prefer that those patients come in person. So what we do, we have a mechanism in our EMR where I send a message or drop down a referral to a pharmacist. So it's a built-in referral saved as a favorite. So I just go in, click on it, and it's a pharmacist visit. And I put in my note why this visit is happening. That visit go in our work queue. And then we have our biologic coordinator who's assigned to go over this work queue. And she calls up the patient and arrange a visit with Sarah. So this is what happens on my side where I send that. Now, if I have like peer-to-peer or denial that is coming through my biologic coordinator, it either goes directly to Sarah, and then Sarah and me communicate in our weekly huddle. If it is urgent, we do it in our daily huddle. So we have like a small huddles that we do, and then we go over that. And sometimes, not sometimes, many times we have patients sending us my chart messages about a drug, their dose, their preferences. They read somewhere, they on Dr. Google or somewhere else, and now they have this question that is beyond the scope of our medical assistant and sometimes even our IBD nurse. So then me and Sarah can just quickly discuss, and Sarah can have a very educated discussion and counseling to that patient that what we need to do and why that particular patient is on a particular drug with a particular dose. So that's how we are working right now, where there's counseling sessions. Sarah has her own block time where she sees patients now. So we book patients for her, and she has a templated visit. So she'll go in, talk to the patient, and do that template. And I think it gets routed to me where I co-sign it and have the ability to read it also and check off and make sure that this is going in the right direction. And we are all in agreement to the plan that we are making. So this is how it's working so far. I've seen the utility and the benefit. Number one, patient gets an opportunity to sit down and talk about the drug, really understand what this drug is about and how this is going to work. And secondly, go over side effects and making sure that they are also aware how to monitor, become self-aware of how to monitor them. And third, they have a connection where they can call the pharmacist and arrange a follow-up visits and then go from there. So this is how the model is working right now in our practice.
This sounds like a wonderful collaborative practice approach. Sarah, anything else to add on what Tauseef described for us, or anything you want to share with other pharmacists who would be interested in being part of this kind of agreement with a clinician?
I think that Dr. Ali covered how we see our patients pretty well, but I think in terms of words of advice for pharmacists that want to establish collaborative practice agreements with providers, I think as long as you're sitting down and you have a good idea between you and the provider of what kind of services you would like to provide, just making sure all of those things are added into the practice agreement so you have all of your bases covered when you first begin to see patients.
Wonderful. Tauseef, I'm definitely going to ask you, how are you able to convince your system to have a pharmacist in your group? But before that, I want to go back to Drea and ask you, Drea, there's so many terms floating around, and maybe you can help us understand briefly these terms: specialty pharmacies, retail pharmacies, and their role in the clinical practice, and how this is impacting IBD practice, and what role can the pharmacist play in helping us navigating these different entities.
Yeah, sure. It definitely is a complex system at times and can be a little bit complicated. So I think, specialty pharmacy is really a focus on, again, I think the name can sometimes be a little misleading, honestly, the specialty pharmacy name, but it's really a focus on these complex chronic disease or rare disease use cases where we have typically advanced therapies, biologics or otherwise, that are complicated therapies that need a little bit of special attention, quote unquote, or ongoing monitoring, focus on adherence. And I think another piece that we haven't explicitly mentioned, but I think what most people think of when we think of specialty pharmacy and these types of medication therapies is really access to them, right? So we all know that they are expensive. And so determining, which leads down the prior authorization and all of that process workflow, determining the most appropriate therapy for the patient, but also the one that's covered or the most affordable for the patient, right? And then at times taking that another step and, looking at manufacturer assistance programs and things like that, because they're not going to all be affordable for all patients, unfortunately. So, but specialty pharmacy is really a focus on that. Every health system and pharmacy benefit managers and some are independent. So some are part of a health system, some can be independent operations. It depends. Insurance dictates a lot of where patients will get these medications from. But the specialty pharmacy, I guess one important thing to note, and we're fortunate to be an integrated delivery network at SSM Health. So we have specialty pharmacies within the system, and we have pharmacy benefit managers. But it is important to note that the role of the clinical pharmacist within the IBD clinic is partially a coordination role between all of these pharmacy partners, right? Because some medications patients are on, they're going to get at their retail pharmacy location, their community pharmacy, for the bulk of their medications. But likely when they get to the IBD therapies and the biologics, there's going to be a specialty pharmacy involved, which could be a different entity. And that specialty pharmacy actually has additional requirements to outreach to patients, educate patients, and do some ongoing monitoring of these complicated therapies as well, which is a good thing, but it often takes coordination between the health system and direct care delivery team and those teams. So it can be a complicated process to navigate, but there are, I think, a good reason that specialty pharmacy has come along, and it really is to take care of these more complicated access issues and monitoring issues of these therapies. But as Dr. Ali alluded to, it's not going away, and there likely are going to be more and more therapies that will fall into that category as well. But yeah, it takes a team to navigate and manage appropriately for patients.
Absolutely. Thank you, Drea. And, we heard from Drea, Sarah, and yourself, Tauseef, how an IBD pharmacist can really be a key player in a multidisciplinary approach to IBD care, and how we can really improve patient care and allow the clinician to really focus on seeing patients, and how a pharmacist is a complementary, actually, in the type of work they're doing in patient education and patient monitoring and disease monitoring and drug monitoring that they're doing. So they do have a complementary role to the clinician seeing the patient with inflammatory bowel disease. So the golden question here is, how do you convince a private practice or a system or a academic institution to have a pharmacist by your side and to help in the care of people living with IBD?
Yeah, that is kind of like a golden question, $1 million question, right? So like, how do you convince administrators to understand and help you out here? So we're just specifically talking about IBD today. So as you know that the IBD practice has also have evolved into different flavors of academic programs, non-academic health systems programs, and then private practices, group practices have also developed IBD programs and centers. So the key thing is, as with universally with any new project, the need assessment need to be determined why you need a pharmacist. You have to convince them, and that convincing will come from your patient load, your prescription pattern of what you are prescribing to these patients, where these prescriptions are going. Third, your existing model of staff, that where you need additional staff to do this and help you with prior authorizations and things like that. So I think the first thing is to develop that need assessment, and then going and having this negotiation with your administration, like, okay, well, this is what we need, and this is why we need. Patient reported outcomes, patient satisfaction. There's enough data that's available in the literature that you can even quote some references in terms of how it improves patient satisfaction, workflow, utility and importance, and where they can play a role. Nice papers out there that can really help you draft down your personalized need assessment and request for getting a pharmacist. The second thing that will come in question is, especially in academic institution as well as in healthcare systems, is how to get the pharmacist once you get approval. Well, let me take one step back. So then the pro forma will come, like how do you envision getting your pharmacist in your practice? In many academic practices, if you get a pharmacist, then you are at your liberty to work with the pharmacist and develop a program. Okay, well, this is what we need to do. I have discovered that crafting, developing this collaborative agreement sometimes could go into red tapeism and could be really, really difficult in many institutions to do that. That's a lot of work. And if you don't have that understanding between your pharmacy department and your department and administration, then things can go really complicated. Luckily, we didn't have that problem. We use and leveraged the existing models that were happening. So that's another key, is to talk to your rheumatologists, talk to your primary care physicians, or even go reach out to your pharmacy department or your pharmacy services and say, hey, if they are already doing this and there is an existing model that you can replicate. The other part, the key part, will be the financial and the revenue part also, like how a clinical pharmacist not only bring value, but also can it be a source of revenue for the section, or at least will help you reduce the cost of the care. Can that pharmacist reduce the, what I call, this is my invented word, DIB, that we use, drug in body. So me and the patient have a discussion today, then how long did it take for that patient to actually get the drug in the body? So we call it DIB, and we monitor our DIBs every month. So how can you reduce that? And by reducing that, you are reducing the patient's chance of flare, disease. So all these needs to be explicitly shared with the administration and the pharmacy department. That will help them understand that why we are needing the pharmacist. Once you get the pharmacist, then you need to make it's like a project. So you have to determine how many patients visits a pharmacist can have. What will be the timeline, or kind of like the schedule of that pharmacist will look like, and how much cost saving or revenue or quality of care will be improved. So we need to quantify all these things for them to understand. I think once you do that exercise, the rest is all easy, because I think we have enough resources and references that we can share with our administration and with our leadership to get this going. And the other thing that I will admit, and I will acknowledge the support of many academic institutions and their pharmacists who really helped us out. University of Chicago, University of Vanderbilt, Mayo Clinic, Cleveland Clinic. We reached out to all the pharmacists practicing in IBD practices there, got the information from them also, like how can we very successfully build a program, getting the best from all the best places and incorporate this into something that can really help. So if any institution, if any IBD expert want us to share some of those information, we'll be happy to reach out to them, and they can contact us, and we can help them how we actually successfully implemented this in a non-academic institution to have a clinical pharmacist. I hope that helped.
Yes, absolutely. Thank you, Tauseef. As usual, the key is collaboration, right? Exchanging information, exchanging experience and expertise. This is always the best way to advance any patient care. So we really appreciate you sharing with us your experience, your tips and tricks. Tauseef, Drea, Sarah, thank you for being with us today. That was really a very helpful conversation. Thank you, everyone who joined us today and listen or watch our video. Please make sure you claim your CME credits by completing the post-test and evaluation in the link below, or by following the QR code shown on the screen. Thank you, everyone.